Okay. Damn it. It's probably it's better. Hi. Let's see if I can put my headphones on so I can hear everyone. Recording. Chat. Okay, so I'm going to talk about COVID-19, and I'm going to try to kind of break down what the virus is, how it's getting to the body. And so I'll wait for everybody to join. And then if you guys have some questions, if I can answer it, I'll answer it. But if I can't, I'll just let you know the resources that I looked at. I'm still looking at something because I had a question myself. Let's see. Nobody else? See waiting room. Let's see. Admit. Though. Let's see. Admit. Who else do I need to admit?
Hello.
Hi.
Hi.
Let's see. So I'm talking about COVID-19 today.
Okay.
And it's not going to be a long meeting, maximum 30 minutes. So you guys have other things to do. And this is supposed to be informative and interesting. Okay, nobody else is in the waiting room. Okay. All right, let's see. If you have any questions, again, if you have any question that I could answer about COVID-19, I will try to answer it. Okay, looks like one more person. I'm probably, just like last time, I'm gonna wait till 8:03 and then I'll start. Who else? Okay. so I'll wait till 8:03. I wanted to look something else up. Yeah. Okay. Mhm. 2 more minutes. Okay. 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 Let's see. All right, so, well, my watch is slower than my computer, actually. My computer is fast. But it's kind of 8:03. One more person is waiting, and can everybody hear me or no?
Yes.
Yes.
Yeah?
Yeah.
Okay. All right, yeah, last time I did this, I had some volume problems, so. All right, I'll go ahead and start. Everybody else who comes later, it's okay. You can just ask a question. So this meeting is going to be about COVID-19 and actually what it is. It's a coronavirus. I'm going to break down what the COVID-19 kind of stands for. Virus is for the vid part. And 19 is named 19 because actually it was discovered last year around November. So that's why it's being called COVID-19. What it's doing, so there's kind of a difference in what I've been seeing in the hospital when it first came out versus what they're recognizing now. Initially, when it first came out, everyone thought it was more of an ARDS, severe hypoxemia, that was refractory. And so we did our standard ARDS protocol, which we did the high peaks of 15 and greater. You did your low tidal volumes, you did 100% FiO2, but you try to wean down lower. So they were trying to keep actually the FiO2 at 60%. Because if you remember, at 100%, you're actually causing atelectasis. And they did the lower tidal volumes of 4 to 6 mL. So I admit another person. Hi, Jonathan. So they did the lower tidal volumes of 4 to 6 mL. And these patients ended up on pressors. They ended up on rotary beds, which are beds that self-turn an adult patient, so you don't have to manually turn it. Although we didn't have that many beds, so we ended up having to manually rotate these patients, which require 4 or 5 healthcare professionals in the room to act, and a respiratory therapist to hold the tube and actually manually turn the patient onto their stomach. Because being in that stomach position, which is prone position, is actually beneficial to recruitment, and also oxygenation is the main reason why we prone patient. In addition, it does kind of help a little bit with your blood pressures because you're not in that 30-degree semi-Fowler's kind of position that's supposed to reduce VAP. And we don't have to worry about VAP when you're prone because all the secretions is coming out because you're on your stomach. So that kind of worked. what was initially happening is these patients, when they presented to the hospital and they tested positive for COVID-19, they were going from nasal cannula to intubation. And the reason for that is because we were concerned about aerosolized particles. Aerosolized particles can stay in the ear for a long time, and things like high flow and BiPAP, even if we added an extra HEPA filter to it, they were concerned about aerosolized particles until they converted sections of the hospitals into whole wings of negative pressure rooms. They only had a couple. Most of the time in the hospitals, on one wing, there's only 2 rooms. They converted a whole wing to negative pressure, on a whole ICU to negative pressure. But we were finding they were going from 6-liter nasal cannula, and if the patient decided on that, they would directly intubate them. So now they're taking a different approach. Now studies are showing that no, they don't necessarily need to be intubated if they're starting 70 on a 6-liter nasal cannula. We can do BiPAP and we can do high flow. And one of the reasons why we're now following that is because more rooms have been converted to negative ear pressure. So that part is changing. Another thing that initially was being done is we were keeping these people, and they're still kind of doing this, we're keeping these people on the drier side for blood volume, meaning these patients are getting diuretics, and these patients aren't getting fluid boluses to the same amount as you would normally give someone. They're kind of keeping you on the drier side so that you don't have fluid possibly going into the lungs and making the pneumonia worse. What's happening to these patients is, since our plan was to intubate them if they required more than 6 liters, prone the patient. When you prone, of course, now you have a vented, intubated patient who wasn't starting well to begin with, who's probably starting 80s, 90s now. When you prone, that's an uncomfortable position to be in for spontaneously breathing awake adult. So they had to do more than propofol. So what was happening is they were paralyzing these patients. And paralytics are not good for adults because first of all, you're paralyzing that diaphragm, and then you're not allowing the diaphragm to work. So it's harder to think about extubating someone. In addition, you're not allowing the patient to move mucus out of the airway themselves. And one of the problems with COVID-19, if we kind of waited too long, it would progress into pneumonia, and they were treating it like ARDS, even though the x-rays didn't have the same diffuse butterfly ground glass appearance of traditional ARDS. You still did have a lot of atelectasis and just basically cloudiness or atelectasis in the x-ray, but it wasn't ground glass diffuse throughout all the lung fields or looked like a complete lung collapse. It didn't look like that. You would still get areas where you would see the black, which would mean that the lung was inflated and had air. Does anyone have any questions so far? I'm kind of jumping around. Anybody? No? So again, what we were initially doing, because we were proning these patients, we had to paralyze them so they can tolerate the whole procedure. So now these patients are still getting paralyzed if they end up on a ventilator, but we're trying to avoid putting them on a ventilator right away. Now we're actually putting these people on high flow like we normally did, like you've learned in school for your clinicals. You only intubate someone if they have severe hypoxemia, if it's really, really bad, and you can't treat it with BiPAP or high flow. If the patient is completely obtunded, if the patient's airway is being threatened, like if someone's having a seizure, those are the reasons to intubate someone. Or also if you have a critical airway, for instance, if they have something wrong with their jaw, you would need to have a secure airway, so that person might be intubated or trached. But we were just going from 6 liters, starting 70, 80% to intubating. So now they've gone back to what used to be our old policy of going through all of the respiratory modalities to help ventilation. And I think that's been working a little bit better. So COVID-19 is actually affecting an adult's type 2 lung tissue. And your type 2 lung tissue, what that does in adults is that's what's creating your surfactant. And it's going through certain channels that the calcium channel blocker drugs, that's why people who have high blood pressure and are on blood pressure medication are at very high risk. The blood pressure medication affects your calcium channels, and these type 2 cells have, I believe it's ACE channels, and then some people on calcium channel blockers and ACE inhibitors. Those people are at high risk because it weakens those channels to begin with if they're on a blood pressure medication. And then COVID is actually using those channels to get into the cell. Once COVID-19 gets in the cell, it's an RNA virus. When it gets into the cell, it does what viruses does. It replicates into the cell and has the cell produce more of itself. And then what ends up happening is that lung tissue, that alveoli starts breaking down. And once that cell itself in the alveoli, once one cell actually dies, the type 2 lung tissue cell dies, it starts releasing chemicals into your bloodstream that warns the rest of your body. So inflammation markers, cytokine markers, and that's what's happening. All the inflammation, your body tries to fight back. So it allows your white blood cells to come and know that you're under attack, but it also produces a lot of histamine. And there's a whole chain reaction for inflammation in your body, and it just kind of gets out of control. And that's what's causing the pneumonia. So it's the whole histamine reaction of your body to this dying type 2 cell because of the virus. In addition, when these cells die, they just kind of slosh off into the alveoli and they stay there. And especially if this person is paralyzed, it becomes congestion, it becomes pneumonia, and that alveoli eventually collapses. And then you have more alveoli going through this problem. There's recent studies that show that instead of ARDS, which is what we were initially comparing COVID-19 to, it may be more like an altitude sickness. Why they're saying that is because you don't have complete lung collapse. You do have severe atelectasis. You do have refractory hypoxemia. You do have PaFiO2 ratios of less than 200. So that would be our normal ARDS marker. But the difference is they're showing it probably is also affecting your red blood cells. And that's why they're calling it an altitude sickness almost as well. So that's what's making the patients very hypoxic, because they believe it's also affecting the red blood cells and not just the type 2 lung tissue that produces surfactant in an adult. And surfactant is what helps reduce the surface tension in your lungs. Now, it was suggested, why not give these people surfactant? Well, one of the issues is if the alveoli already has dead type 2 cells and dead tissue, then the surfactant can't evenly distribute into the patient's lungs. And if surfactant isn't evenly distributed, one of the risks of surfactant is a pneumo. So, and surfactant administration to adults is also not shown to do much. So that's why we're not giving these patients surfactant, even though we know that's what's being affected. And so some new drugs, so we weren't doing any steroids either. I'm not exactly sure why the doctors weren't giving steroids, but I do know it was a recommendation from WHO and from the CDC. So they weren't giving these patients any inhaled steroids. They're trying to stay away from steroids. These patients are on diuretics. These patients are on paralytics. They end up on pressors, because if they get really bad and they become septic, then we have to put them on medication to increase their blood pressure. What else can I tell you? So the newest thing that they're doing now is they're doing phosphodiesterase inhibitors, and they're giving a medication called acetazolamide as well. And so acetazolamide has been found to reduce hypoxic pulmonary vasoconstriction and improve minute ventilation and expired vital capacity. So that's something a little bit new, because they were testing out various kinds of drugs. They were testing out drugs that they use for people with autoimmune disease. And they were also testing out, what was the other one that they were testing out? It's another kind of drug that they were testing that I forgot now.
Tabitha, how do you spell the name of that drug you mentioned?
Yeah, it's ACE Tazolomide, acetazolamide.
Awesome. Thank you.
They're also giving these patients phosphodiesterase inhibitors. Most of the new meds, they were giving these patients AIDS medication as well, but they've kind of come away from that. Most of the new meds that they're giving the COVID-19 patients are medication to reduce the inflammation reaction of the body and should suppress the body's overreaction to the virus, because it's the body's reaction to the virus and all the inflammation, all the histamine that is produced that's actually causing the pneumonia, on top of the fact that the cells are dying. So that's actually what's making it so bad. Let's see. So we've actually been having patients surviving now and not having to need mechanical ventilation. Yeah. So does anyone have any questions? I think that's pretty much everything I know thus far. New studies are coming out all the time. I do have a website from the National Library of Medicine. If anybody's interested in reading the article on it, it talks about acetazolamide and another one I can't pronounce, I'm not even gonna try, and phosphodiesterase inhibitors, and kind of explains why they started giving this type of medication for COVID-19. If you're interested in reading it. It's basically, it helps with the hypoxia, your PaFiO2 ratio. And then in the end, our ultimate goal is to make sure if these patients do get intubated that we extubate. And now that we're able to extubate to high flow again, we have more choices. So they don't have to be well enough to extubate to a nasal cannula, which was the case before. But now we can go back to high flow BiPAP to extubation. So let's see. And that's it. What time is it? Yeah. Anyone have any questions? No? You're good? Everyone's good? All right. All right. So thank you. I hoped it was informative. Obviously, there's more information coming out every single day. But patients are getting better from it now that we know what to do more. And it's basically about doing the minimal vent settings that we need for this patient and making sure that we help oxygenation. That's pretty much it. Thank you.
Okay, thank you.
Thank you.
Thank you.
Bye.
Thank you.
Let's see, and